Folks, thanks for your patience. Really appreciate it. I'd like to welcome you all to the final event for Humans Meet Honour Pride events and exhibition programme. Humans Meet Honour Pride interrogated the seismic changes that are happening around AI and robots. And we're delighted to have Dr. Matt Hewitt, consultant obstetrician and gynaecologist and senior clinical lecturer at University College Cork with us this evening. We're going to be looking at, I guess, the future of surgery and emerging technologies in the field. We're going to have probably about an hour with Matt, and then we'll be doing a Q&A afterwards, so feel free to hold off on questions till the very end. We just give Matt a round of applause.
Ola, thanks very much for the invitation to speak. And like Ola said, I'll answer any questions at the end. Presume you can all hear me. So first of all, I'll try and advance my first slide. Yeah. So just a conflict of interest. So I'll be mainly talking about a robot called Vinci made by Intuitive Surgical, and I have worked for Intuitive Surgical, so that may make me a little bit biased. And I also have an Intuitive Surgical robot that I use, so that in itself probably makes me a little bit biased. But the talk is really to show what it can do and show what great fun it is, and just show the innovation that we have and we have for the future. So a couple of basic sort of surgical things I want to talk about. Firstly, the idea of laparoscopy and laparotomy. So traditionally with surgery, we used to have large incisions called a laparotomy, but now we have small incisions called keyhole surgery, laparoscopy, oscopy being telescope. And similarly, we can do a thoracotomy where we make a big incision, or we can do a thoracoscopy where we make small incisions. And you can imagine one is a little bit more painful than the other. So we've moved towards a laparoscopy and thoracoscopy. So the abdomen and the thorax, they're cavities. And what we do with laparoscopy and thoracoscopy, particularly laparoscopy, and that's what I'm going to talk about, is we blow the abdominal cavity full of carbon dioxide, so it lifts the abdominal wall up and creates a cavity by which we can then operate on the internal organs. So you can see there's no air in the abdominal cavity other than the bowel itself. But when we insufflate, we put air in the abdominal cavity, in the peritoneal cavity. We can then put instruments in and we can look at the internal organs. Now, I'm a gynaecologist, so I'll be talking a bias towards gynecology, but this applies for general surgery as well and urology. So a laparoscopy, keyhole surgery, or minimally invasive surgery, all terms that I'll use. So what are the benefits of laparoscopy versus laparotomy? Well, you get less scar tissue, so it doesn't look as bad. You get less pain following the surgery, and you can do quite large abdominal procedures, and the patients can go home the next day, whereas if you do a big midline incision, they'll be in for 4 or 5 days. The patients make a quicker recovery, and they have a quicker discharge from hospital and less blood loss. Now, speed isn't everything, but a night in hospital is anywhere between 500 and 1,000 euro. So if you can get a patient home 1 day earlier, then you're saving the hospital 1,000 euro. Now, you're often getting patients home 4 to 5 days early, so you're saving a lot of money if you do the keyhole surgery. Plus, these patients get better quicker, which means they get back to work more quickly, and they have less complications by the fact that they mobilize more quickly, less chance of getting clots, less chance of getting bowel complications because they're up and about a lot more quickly. But laparoscopy can sometimes not be appropriate for every single patient. So sometimes it can be more difficult to do laparoscopic surgery as opposed to having an open incision. It can sometimes take a little bit longer. The equipment can be more expensive if you're doing it laparoscopically. You get less manipulation of the instruments with conventional laparoscopic surgery because your hands can move in all directions, but ordinary keyhole surgery, they can't. And you lose that touch feedback that you get when you're touching organs internally. You can feel things. With ordinary keyhole surgery, sometimes you can't feel that tissue. And with ordinary keyhole surgery, you're looking at a flat screen, so you're seeing things in 2 dimensions. Whereas in open surgery, you're seeing things in 3 dimensions, you get that sense of depth. And then sometimes you're looking at a screen, even though you stood next to the patient, the screen is a bit further away and you're a bit distant from the patient and it doesn't really quite seem as though you're operating on the patient. So your hands may be operating on the patient here, but you're looking at a screen over there. So you have to suddenly think, are these my instruments? And you sit a little bit distant from the patient. And if you're doing a long procedure, some procedures take 2 or 3 hours, you stood up, people get back pain, shoulder pain, and that can be obviously quite uncomfortable. And one of my colleagues in London says when he does a long case with ordinary keyhole surgery, it takes him a day to be able to feel his thumb afterwards because it's basically got numb and it's been traumatized. And you're also heavily reliant on an assistant to hold the camera, to point it where you want it to point, and also to help you with other instruments that they may be holding. So there's got to be a lot of interaction between the two. So it's not perfect in any way, but it's better than laparotomy. Now, my button's not very sensitive. There we go. Now, what I'm going to be talking about mainly today is what we call the Vinci Robot made by Intuitive Surgical. So this was a company initially set up with NASA and the American military to sort of look after patients, be it a soldier on the front line or be it an astronaut. But as you'll see, it's a long, long way from being anything that can go to the front line or up into space. So they sold it off to a private firm that now have taken it on. And this is the most wildly used robot in the world. And this is the one that we're going to be mainly talking about. But there'll be other robots we talk about later in the program. So you can see there are 3 components. So in this diagram, the patient seems to have disappeared. I don't know why. There should be a patient there, okay? And you can see these trocars, these little ports going into the patient's abdomen if the patient was there. And the surgeon is sat at a console here controlling this robot. This is called the cart. Sorry, this is called the console. This is called the cart. This moves up towards the patient. You put the trocars through the abdominal wall, blow up the air, and then you operate from a slight distance. And these are just a bit of electrical equipment. So this surgeon is normally 5-6 yards away from the patient, but could be 3,000 miles away from the patient if you've got a good internet speed, which the HSE doesn't have. So what I'm going to do is, as I'm talking a little bit for the first bit of the presentation, I'm going to show you an operation. So this is an operation unedited. This is going to be a hysterectomy. So imagine you're sat on a patient's head and you're looking down into the pelvis and you begin looking down on top of the uterus. So this is the uterus here, and this is the right adnexa. These are the fallopian tube, and you'll see a white thing there hanging down. So this is an operation you're going to watch from start to finish, okay? And as I describe the features of the Intuitive Surgical Robot, we'll reference this particular diagram. Now, it's an unedited surgery. When I see other people giving presentations, they edit their surgery. They show you their best bits. Of course they do. This is unedited, so there are a few little mistakes. Nothing bad. Patient's fine. So this is the robot in action. So you can see the little trocars, the thin little holes in the patient's abdomen. There's the camera one, and there's 3 instruments, there, and there. And we've got a free port here. This is the patient's head here, looking down towards the pelvis. This is the camera one. Look at the picture there moving as the camera moves. You see the picture moving? And then there's a nurse doing nothing. And there is my colleague, Dr. O'Reilly, who's operating the robot just from a few yards away, okay? And you can see he's got his hands and he's manipulating the instruments from a slight distance. So what are the advantages? Well, if you look at the endoscope, which is the camera that goes through the middle trocar, you see there are 2 camera heads. So those 2 camera heads project to the patient's eyes, and they're slightly far apart. And what you've got in the console, you've got 2 eyepieces, each that correspond to those 2 camera heads. So when you're looking down at the console, you're seeing things in 3 dimensions. And that's what you don't have with ordinary keyhole surgery. So you've already got 3 dimensions, you've got that sense of depth, and that's really, really helpful. And you can see where that's drawn. Imagine you saw the picture of the surgeon at the console. He was looking down at their hands. But they're not seeing their own hands, they're seeing the instruments. So suddenly it makes you think that those instruments are your hands, and you feel as though you're within the patient's abdomen. So you get this immersive feeling, traditionally, like traditional laparotomy, where your hands are in the abdomen and you were looking into the abdomen. And that's what it mimics. It mimics the old surgery, the old laparotomy, what we used to do, as opposed to the distant two-dimensional screen that we're seeing. And as we're looking down in the console, we have a field of view, probably about 70 to 80% is the operation field itself. Whereas with conventional laparoscopic surgery, looking at a screen, it's probably about 10% of the field of view. You may have a window in the corner, you may be looking at the other surgeon there. So your field of view is much less of the operation field than it is with the Da Vinci robot. But that immersion in the patient and that 3D view is really helpful. Now, with ordinary keyhole surgery, you put your instrument in, you can rotate it and open and close it. But with the Da Vinci surgery, you have 7 degrees of movements. So you can see Dr. Riley here bending, articulating his wrists. So he's got articulated instruments. And if you look at the surgery here, see that little pair of scissors there? It's just got a slight bend on it. Okay? And you can see manipulation, 7 degrees of movement. And you don't have that 7 degrees of movement with ordinary keyhole surgery. So you've gained an advantage over conventional laparoscopic surgery. And these are called endo-wrist instruments. We put these metal trocars through into the patient's abdomen. And we just unclip them when we finish the procedure. And it's just crashed a little bit, so yeah, there we go. Now, you can see the range of movement that we have. So the trocar is there. We have a massive range of movement. And you can see there's a little black line just there. And what we do with that little black line, which is there, we line that up with the patient's abdominal wall. So when the trocar is moving, the bit that's actually attached to the abdominal wall is not moving at all. It's perfectly stationary. So you can see there, that thick black line is actually not moving. So although there's a huge degree of movement of the robot itself and of the tip of the instruments, the abdominal wall movement is minimal. With ordinary conventional laparoscopic surgery, imagine I move my hand to the right, the instrument tip would move to the left. So everything you do is in reverse. But with the robot cancels that out. So if I move my hand to the right, the instrument tip moves to the right. Even though it still has to act around a fulcrum, because the engineering, the mechanics and the electronics, it cancels that right-left movement out. So every time I move my hand to the right, the instrument moves to the right. And with ordinary conventional laparoscopic surgery, the sort of abdominal wall is holding the trocars. With the robotic surgery, the robot is holding the trocars. Therefore, there's some evidence, not strong evidence, that it decreases the amount of pain that a patient will have. Now, if you can see here, the camera just moved. See the camera moving there? So the surgeon, when he touches the camera pedal, which is just here, when the surgeon moves their arms, the instruments remain stationary, but the camera moves. It's a little foot pedal. So if I want to zoom in, press the foot pedal, I push my arms away, and I zoom in. let-go-of-the-foot pedal, I'm in control of the instruments again. If I want to zoom out, I press the camera control, and I pull my arms towards me. The camera zooms back out. I release the foot pedal, and I'm controlling the instruments again. And I can rotate the camera, so I can turn the camera. And you can just see, just there under the logo, there's a little camera. That's an horizon monitor, like on an aeroplane. So on an aeroplane, if you bank one way or the other, there'll be a little icon that rotates. So that will rotate if you turn the camera, so you know if you've tilted the camera a little bit. And we also have another foot pedal called the clutch pedal. So the clutch pedal means that if I hold the clutch pedal down, I can move my arms and nothing will move. So if I'm suddenly operating like this and I'm uncomfortable, I press the clutch control on the robot, I move my arms to a more comfortable position, nothing will move, I release the clutch control, and then I'm in control of the instruments again. And what you can see here is there are two instruments here, and you can just see the third instrument somewhere hiding. I can move all 3 instruments. So if we wait for a second, instrument 1 is this one here, instrument 2 is this one here. See, they're highlighted because they're moving. Instrument 3 is currently not highlighted. It's not actually on the screen at the moment. But if I just tap the clutch pedal, I will flick between instrument 1 and instrument 3. Now, you can only control 2 instruments at any one time, but you will be able to move between the 2. And if I wait a second, you'll suddenly see that flick. Now, there's the other instrument there. See it flick there? Flick 1 to 3. I've pressed the clutch control. Scissors are not moving. Now instrument 3 is moving. And I click back, and now instrument 1 is moving. You see how quick that was? So when you see a surgeon operating with the robot, their feet are tapping all the time because you're flicking between instruments, you're moving the camera. That's with your left foot. With your right foot, you have what we call electrocautery. So a lot of surgery, be it open or be it keyhole surgery, is done not using knives, but using electrocautery. And so we have, in this instrument here, number 2, there's number 3 moving, we'll get that out of the way. So number 3 here, if you watch this now, you'll see some little bit of smoke there, okay? That's called bipolar. So there's a current going down the instrument, into one jaw, across the tissue, through to the other jaw, and back out again. And bipolar is an electrical circuit which creates a lot of coagulation and sealing of tissue. But it doesn't cut it, it just seals it. So on my right foot, I have a bipolar pedal, which I control the bipolar current. And on the scissors just here, we have scissors, but we also have a current called monopolar. And you can see that's just cutting there. So this current is going down the tip, through the patient, to a pad on the leg, and then back to the instrumentation again, so creating a circuit. So monopolar current going through the patient is very good at cutting, but not so good at coagulation, and the bipolar is good at coagulation. Now that's the same with laparoscopic surgery, with conventional surgery, and with open surgery, but the beauty of the robot is you've got them both there ready, as opposed to having to take one instrument out and put another instrument in, which you have to do with conventional laparoscopic surgery. So I'm controlling those with my right foot. So I've got the clutch on my left foot, I've got the camera on my left foot, and on the right foot, I've got the monopolar and the bipolar. And a bit like when you drive in a car, the first sort of 10 times you're operating, occasionally you have a quick sneaky look and say, where are those foot pedal again? Yeah, there it is. But as you get used to it, about 10 cases, you just forget, and you're doing lots and lots of work all the time. And like I said, a good surgeon is tap dancing throughout the operation, and constantly the instrument's in a comfortable position. You also notice that the camera is perfectly stationary unless I move the camera. So you're not relying on assistants to move that camera for you, because assistants can get a little bit bored. They may have been out the night before, they may be chatting up one of the nurses, there may be a conversation going on. Suddenly the camera will drift, and then suddenly you'll be operating in the top right-hand corner of the screen. You're going, whoa, 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 move, I want to operate here. Or they may not know what you're trying to actually achieve. Whereas with the robot, I'm controlling the camera. It's my job to put it in the right position. And similarly, I'm controlling 3 instruments. Despite only having 2 hands, I'm controlling a camera and 3 instruments. With conventional laparoscopic surgery, you can only control 2 instruments at a time. And although with robotic surgery, we often have an assistant port, so they can put needles in and do a little bit of suction and assist. With ordinary laparoscopic surgery, you're using the assistant all the time. Now, we also have something called telestration. So on this little screen here, we can draw, and a little line will appear on the console. So if I'm teaching one of the junior doctors how to operate using the robot, and they're getting a little bit stuck, I can draw on the screen, and they can see it on the console. So I can say, look, cut here, or push that there. And as soon as they move the camera, that drawing on the screen disappears, because, of course, that drawing is no longer relevant to the image that they're seeing. Or I can do the sort of opposite, where if the registrar junior doctor is operating, and I want to teach the medical students, I can draw on the screen, but press a button such the surgeon doesn't see what's going on. So it's called telestration. And similarly, that could be 3,000 miles away if you were drawing and trying to help a new surgeon. I don't know why it's always 3,000 miles. I know that's some distance between Europe and America. I don't know. It's always 3,000 miles that everybody says. Now, with the robot, we can change instruments. So there was an instrument that came out, and we're going to put a new instrument in. And that's how quick it is. And if you watch the instrument tip just there, I'm going to take that one out. I'm going to put a new instrument in. Look where the laser pointer is. Straight in. Bingo. To exactly the same place as where the other instrument was, minus 3 millimeters. So it goes into exactly the same place. So you don't have to track the instrument out and then track the instrument in, and suddenly it's pointing the wrong direction. You have to go and try and find it with a camera with ordinary conventional laparoscopic surgery. It's got memory. It knows exactly where it has to go. Okay? And at which point, what I'm going to do is we have some instruments here. Okay? These instruments have been used already on a patient. In fact, they've been used on 10 patients, but they are sterile, okay? So if you want to hand them round, there's the instrument tip. You can see the lovely pulley articulation mechanism, and you can see the wires there are joined to these bits here, and that clips onto the robot, and there are discs on the robot that spins these, which then controls the instrument tips. So have a good play with those. You can see there's a serial number on them, and that's relevant for a little bit later on. And you can see there's also 4 little gold things there where there's a lot of feedback and information going through. So please spend your time passing those around. I'll put one there, and I'll take one over that side and just pass them around. They are sterile, I promise. Now, we talked about having only one console. You can actually buy 2 consoles. So you can have 2 surgeons actually operating at the same time. So when I say can only move 2 instruments at once, well, in fact, if you have 2 consoles, you can move 3 instruments at the same time because the other surgeon controls the other instrument. That's good for teaching. And again, that could be 3,000 miles away. We don't have that in Cork, unfortunately, because we can't afford it. And the other thing you can have is what we call superimposed radiology. So you can actually put a CT scan picture in the corner of the screen to help you try to visualize which bit of organ, which bit of tumor you're trying to resect. Again, we don't have that. We've got the older version. Now, surgeon comfort. Is surgical comfort important? Well, yes, it is. Just before we go into that, we're getting near the end of the operation, okay? So we've released most of the uterus. This is a metal ring that's in the vagina. So we're just releasing the uterus from the vagina. And then you're going to see eventually at the end the uterus disappearing through the vagina. And then we're going to close the top of the vagina up. So there's our monopolar. So surgeon comfort, is that important? Well, surgeons get paid quite well. And if a surgeon got back pain and is off for 3 months or 6 months, well, they're useless to the HSE and they cost a lot of money. So being comfortable is really important. And you can see here, I look reasonably comfortable. I've got a little bar there which I'm resting my arms. So I'm sat down and I'm resting my arms. And like I said, with the clutch pedal, if I'm suddenly hyperextended or hyperflexed, I press the clutch pedal, I move my arms, nothing will move, get my arms comfortable, release the clutch pedal, and suddenly I'm in control of the instruments again. And this console can move up and down, so therefore it should be at your height, and obviously you can move your chair up and down. And in fact, in the newer versions, you can program it to your settings. So you tap in your name, and then if another surgeon's been on it and moved everything, you press your name, and the whole thing will move to your settings. With conventional surgery, be it laparotomy or be it conventional laparoscopic surgery, you're very much scrubbed in and sort of attached to the patient. And sometimes surgery can be quite stressful and you want a bit of a break, but you're scrubbed in, and to sort of step back, you're sterile, you've got to sort of unscrub and then get back in again. And you feel as though you should be there all the time. With the robot, I'm not sterile, therefore I can just wheel the chair back, I can sit back, I can have a chat, have a glass of Coke, and I can chat to somebody, relax a little bit, make sure everybody's comfortable in the theatre, and then once everybody's relaxed, go back in and start operating again. And that happens occasionally in quite difficult cases. And it's good for a surgeon to be relaxed. And like I said, economically, it's also important that we don't get surgeons that are unwell. So one of the advantages of the robot, it's been shown to have a quicker learning curve compared with conventional laparoscopic surgery. In other words, once you start using it, you pick it up much more quickly than conventional laparoscopic surgery, because remember, there's so many things laparoscopic surgery. You move your arm to the right, tissue goes to the left, it's a bit distant, and suddenly you're a bit awkward. And seeing junior doctors operate at the beginning with laparoscopic surgery, it's quite stressful for you as a surgeon, because it's quite difficult then for them to learn, which it was for me as well. With the robot, your learning curve is much more quicker. And there was a great experiment done by one of my mates in London at the Marsden, where he grabbed some medical students and he put some on a conventional laparoscopic training box, and he had a circle of paper. And on that circle of paper, there were 2 radial lines, 2 inner circles, and they had to get a pair of scissors laparoscopically and cut between the 2 circles to create another circle. Yep. So they were cutting between the 2 lines, and if you crossed the line, then you sort of failed. So he set 10 students going on that, and then he put 10 students on the robot, untrained, just chuck them on the robot and said, do the same thing. And quite clearly, the ones on the robot were just much better. And he actually has the drawings of the pieces of disc that they've tried to cut. So the learning curve is much quicker. And also what I find is when I put some of the junior doctors on the robot and get them to do quite a difficult operation, if they then go back to conventional straight stick surgery, they're actually better at the straight stick surgery because they've learnt techniques on the robot that help them to adapt their technique and do it to ordinary conventional laparoscopic surgery. So in that respect, it's also advantageous. Now, unfortunately, we finished the operation. This is conventional laparoscopic surgery, okay? So you look at the camera, it's pretty stationary unless we're moving it. That's because we actually recorded this, and I said to them, keep really still. What I should have done was done a real-life one and not told them I was recording, because like I say, they're all over the place, okay? But you can see these instruments, I call them straight stick instruments. You see, there's no articulation. So if I want to get round a bend, I can't get round the bend, okay? And you just don't really get that wonderful 7 degrees of movement. And we've still got bipolar here, and we've got a little blade in there, but it's just not as stationary. You see, there's all that little micro movements, and the robot cancels out those micro movements. So everything's very steady and very still, unless, as a surgeon, you're wanting for it to be different. So are there disadvantages to the robot? Of course there are disadvantages. So it takes up a little bit of space. Now this is it not in use. So there's the console, and there's the cart, and there's the electrical stack. So you can see we're doing conventional laparoscopic surgery there, and it's shoved in the corner. Our theatre isn't huge. It takes a bit of space, but it's not really such an issue. Could it decrease your straight stick skills? Well, it might do. So not every robot, every surgical case should be done with a robot. On the contrary, it only needs some of the more difficult ones. And therefore, it's important that we still maintain our straight stick skills. Like I said to you, once you start doing the more difficult operations on the robot, you apply some of the techniques to the ordinary straight stick surgery. So it's not really going to be, it's not an issue. We have to train the nursing staff to set up the robot, and obviously train ourselves to actually use it. Does it break down? It has broken down a couple of times. So what do you think we do? Turn it off and turn it back on again, and suddenly it starts working again. And what happens is ours is connected to the internet, so occasionally you may get an error code. And that error code is transmitted to Sunnyvale in California, where they make it, and they can look at the error code and they say, yeah, it's this, don't worry about it. Or they'll say, yes, there's a fault, we'll send somebody over and we'll get it fixed. They can't record what you're doing, and there's obviously an agreement that we sign. It's purely for the error code, so they're not keeping an eye on you. Well, maybe they are. Now, there's no haptic sensation. So I talked about the touch. Haptic is touch. So with open surgery, you're feeling the tissue. With conventional laparoscopic surgery, you can feel something hard, you can feel something soft, and you can pull a little bit, you get a set degree of tension in tissue. With a robot, there is no haptic sensation at all. That's what the companies say, because they have to say that. But There is really, because the optics, the visualization is all so brilliant and you're immersing the patient. In fact, when you move an instrument and you hit something hard, like the metal ring we saw before, or the tissue is a little bit stiff, you can actually feel it. But whether you're really feeling it or it's your brain interpreting that sensation, I don't know. But you can definitely feel it. So they say there's no haptic sensation because legally they have to say that, but there is definitely haptic sensation. But all the problems with a robot, that would be the last thing I would change. It doesn't bother me. I've never ripped a bit of tissue or caused damage by pulling on something too hard. And therefore, your brain begins to adapt because of that reduced haptic sensation. It takes a bit of time to set up the robot, and it takes a bit of time to dock it. So the main disadvantage is essentially, well, the only disadvantage really is the cost. And it's all about money, isn't everything? So the initial outlay. So we got for 1.3 million euro. That was, I think, 2006. And we did a little bit of deal because the Galway clinic got one at the same time. So we got together and said, look, if you buy one, we'll buy one. We'll get it cheaper. So we did. So we got it at a cheaper price. Even though ours is actually an HSE-owned one, the Galway clinic is a private one. So the newest version, which I'll show you later, is 2.1 million euro. There's also a service charge. So every year we pay about 120,000 euro for it to be serviced. So what does that mean? Well, it means if there is an error, they'll fly out the next day from the UK and they bring a service engineer and they fix it for you overnight. And the service you get from it is actually very, very good. Sometimes they can just fix it by fiddling with it. But sometimes what they do, they bring these huge suitcases, and in that suitcase is a robot arm. So they just lift off one robot arm, put it in the suitcase and put a fresh one on. So the robot we had back in 2006 is not the same robot we've got now. It's an imposter, okay? But it still works. Unfortunately, at the end of the year, it's not going to work anymore because the service contract will no longer be valid because they say they can't get the parts for the older version of the robot we have. So our robot is going to die this year, which is a big problem. And there's also the consumables. So each of those instruments, which one's there and one's got somewhere else, each of those instruments costs about 2,000 euro. And you can only use them 10 times. So that's 200 euros per patient. You saw the procedure I did, I think I was just using 3 instruments. So it's 600 euro plus the drapes, 200 euro. So you're already up to 800 euro. If I do a complicated case, I use 4 instruments, that's about 1,000 euro. So they're quite expensive. And because there's little electronics on it, if you try and click it in, for the 11th time it goes, and it will not let you use it. There is a company in China that make them a lot cheaper, lo and behold. But the problem with that is, if the company know that you're using them, suddenly your service contract gets a little bit legally, a little bit dodgy. And there's talk about people putting a bit of silver foil in to try and fiddle it around, but we haven't done that. But at some point, there's going to be a legal challenge about the use of third-party instruments. And I think probably Intuitive Surgical will lose that, and in fact, you should be able to use those instruments. But you can see it's expensive. And that's really the only downside of it. But as I'll show, that hopefully it actually, in the long term, will save money if you use it appropriately. But the other thing I mentioned is, again, at the end of the talk about there is no competition at the moment, but as we get competition with new robots, that should bring the price down. I talked about setting up the robot. So you have to sort of set it up, drape it, and get it ready. And you can see this is back in about 2007, I think it was, 2006. It was taking about an hour and a half just to set the thing up. But as you get more experiences, the nurses set it up in about 20 minutes or so. And what we do is we have the patient anaesthetized in one room while the nurses are setting up, so there's a bit of overlap time. So really the setup isn't such an issue once you learn how to do it. But you have to learn how to do it. And it is sort of fiddly, like any bit of technology. It is a bit fiddly when you first start off. And then we have this thing called docking. So docking is when we put the trocars in the abdominal wall, we have to push the robot cart up to the patient and clip the robot onto the patient, onto the trocars. That takes time. And again, when you first start, it takes ages. But after about sort of 15, 20 cases, it's taken about 3 minutes, which is not that long. And you can see suddenly for some reason, after 48 cases, suddenly we went up to 20 minutes from 3 minutes. And why was that? Because the junior doctors all changed. So I had to teach the new set of junior doctors how to dock the robot. But again, that's part of the learning process. That's like in all medicine. You have to teach people. And you are very reliant on the nurses. And we've got a fantastic bunch of nurses in Ireland. And people actually come to see us operate, not to see me operate, to see the nurses setting it up and seeing how to actually use it. And it's thanks to them that we've managed to keep the program going. So we talked a little bit about some of the what we call a simple hysterectomy. This is a picture of a radical hysterectomy. It's a much more extensive procedure. The one that you saw before was actually a bit of an easy case. This is called the pelvic sidewall, and this is a much more complex operation that we've done. So in gynaecology, we can use for simple hysterectomies, radical hysterectomies where we're doing cancers. A trachelectomy is a radical excision of the cervix to maintain fertility, where we've got a cancer of the cervix. We also use it for removing lymph nodes to see if cancer is spread. And this is the pelvic sidewall where the lymph nodes were. We can also use it for endometriotic surgery, for removing fibroids. That's a myomectomy. We can put a stitch around the cervix if somebody has recurrent miscarriage. We can put a stitch around the cervix to stop them miscarrying. And sacrocolpexy, that's a prolapse operation where we can hitch the uterus up or the top of the vagina if there's prolapse in older women. And we can do tubal reanastomosis, which we don't tend to do in Ireland because there's not much call for it. Now, I'm a gynaecologist, that's why I've sort of weighted this towards a sort of gynecology surgery. But the urologists are using it. And initially, the urologists were the biggest users of the robot, but now the gynecologists have overtaken. And particularly with urology, it's you doing prostatectomies. So men with prostate cancer, they're doing radical prostatectomies. And that's one of the big uses of the robot. The general surgeons are using it, not as much as the urologists and the gynecologists, but the general surgeons are using it. And the thoracic surgeons are also using it, and ENT, so they're putting the instruments down the mouth and operating on the back of the throat. And also head and neck surgery. And you think, well, how can you operate on the neck with a robot? Well, it's quite clever. So with ordinary, for example, if you're having your thyroid removed, you tend to end up with a scar here that's really quite visible. And obviously having a scar on your neck is not particularly nice because people would tend to be drawn to it, and it can be quite distracting and not particularly pleasant for patients. So what they can do is they make little incisions here and here, and they undermine the skin. So they literally, you lift the skin up and you lift the skin up and you undermine it, all the way up to the neck, so the skin is being lifted up, and then you can operate on the thyroid using the robot instruments without any scars that are visible because the scars are down here on the chest. And that's really quite clever. I've never seen it done. But it was just to show that there are other specialties using the robot. It's obviously not just gynecology. Now, this is just one thing I was going to ask. Is there any medics in the audience or not? There are some medics in the audience. Okay, so we'll do a little bit of anatomy lesson. Okay, so pelvic sidewall, external iliac artery, external iliac vein, internal iliac artery, obliterated umbilical artery, uterine artery, ureter there. See it vermiculating. So the ureter goes between the kidney and the bladder. So we've got all these really important organs, and I've got to divide the uterine artery. This is a radical hysterectomy. So you can see that uterine artery is about 2 or 3 millimeters in diameter. So I've had to expose the whole of that area. I've removed all the lymph nodes. It's quite intricate surgery just to get to that one little bit there, and you can see the precision you've got. Okay? Now, there are some surgeons that can do that with ordinary keyhole surgery, but they won't be able to do it as easily or as fluidly as you can with the robot. Now, obviously, I'm biased. You should be saying, show me the evidence, okay? So if I said it could do all these things, well, how can I demonstrate it does all these things? Well, what we do is we look at papers, we look at research to see if there is a benefit. And there's lots of different types of research we can do. So quite early on, we did a study where we looked at other people's studies to see if laparoscopic surgery was any inferior to robotic surgery. So I'm not going to talk about robotic surgery versus laparotomy, because quite clearly the robot will win a hands down. What we've got to do is compare ordinary keyhole surgery with robotic surgery. So we looked at lots of different studies to see if there was a benefit. And these are lots of different studies. And you can see there's the thick black line there, a zero probability mean there's no difference between the two. And this is looking at blood loss. So you can see everything is favouring this side of the line, favouring robotic surgery. Not every single study was, but favouring less blood loss with robotic surgery compared with laparoscopic surgery. This is not randomised data, we'll talk about that in a second, but there is some evidence there. So we looked at various different factors. So the estimated blood loss, robotic ordinary keyhole surgery, less blood loss. Transfusion rate was less. Having a unit of blood is about €500 to €1,000. So if you can reduce the blood loss by using robotic surgery, you're going to save money. The complication rate was less with a robotic group compared with the conventional laparoscopic group. The conversion rate. So conversion is when you start off with keyhole surgery, be it conventional keyhole surgery, be it robotic surgery, but then you can't manage, so you have to convert to a big midline incision. So not only have you wasted money because you've used all the equipment and you still have to open up, you've also inflicted more pain on the patient because they're having a laparotomy, and also you've wasted time in theatre because you've got to set everything up and you still have to open them up. So the conversion rate is a really important factor in terms of saving money. So that study, this collection of papers suggested there's less conversion. And the operating time was slightly more with the robot, but the length of stay was slightly less with the robot. And we keep seeing this slightly less length of stay with the robot compared with laparoscopic surgery. And remember, really, the robot is just laparoscopic surgery using a tool. But for some reason, we seem to get slightly lower hospital stays. Whether that's a true thing or whether it's because people have the robot tend to get their patients home a bit quicker because they're hard and they chuck them out of hospital, I don't know. But there is this general trend towards a quicker hospital discharge. Now, this is one of the very early study. This is looking at one surgeon. So this is a surgeon called John Boggis that works in North Carolina. He's been to Cork. He likes his Guinness. And he's a brilliant surgeon. If you ever go online and watch his surgeries, you just stand back in awe. He's a fantastic surgeon. And he used to do a particular operation for endometrial cancer where he did a hysterectomy and did lymph nodes in the pelvis and he removed paraortic lymph nodes. Huge operations. He used to do them open. Then he started using conventional keyhole surgery. I realized that was better. And then he got a robot, so he started using the robot. So he compared his data between the open, the straight stick, conventional laparoscopic surgery, and the robotic surgery. And what he found was that his blood loss, so that's open, laparoscopic, robot. So his blood loss was less with the robot group compared with the laparoscopic group, so less blood loss, and a lot compared with the laparotomy group. His length of stay, again, slightly less. And the other parameters in terms of number of lymph nodes and things were pretty much similar. Now, if you look at his operating time there is less with the robot compared with conventional laparoscopic surgery, but it's more than his open. So he was taking longer with his robotic surgery compared with his open surgery. But this was after about 50 cases. If you ask him now, he's even quicker than open. So he's got better just in the time that he first published this study. So he's a very good surgeon. He's now much quicker than conventional open surgery. And obviously look at the length of stay, 4-5 days compared with the robot 1 day. Now, you may say, well, it's only 3 days, but that's a lot of money. It's a lot of money. 3 days in hospital is a lot of money. So suggesting that you could save blood loss, reduce blood loss, and shorter hospital stay. Now, that's looking at lots of different studies, combine them together. That's looking at one surgeon and looking at that particular surgeon's data. And then one thing we've got is a study where they looked at a service that a hospital provide. So this is in Marsden in London, where they are a tertiary referral centre, so complicated endometrial cancer patients get sent to them. And they initially had conventional open surgery and they had laparoscopic surgery. And then they were given a robot and they started using the robot. So they looked at their outcome measures before they had the robot and after they had the robot. And they measured everything. So the time in theatre, how much that cost, the complications, the blood loss, the biochemical costs, the instrument costs. They were measuring absolutely everything. And what they showed was, because of the lower conversion rate and the less laparotomies they were doing, they were actually saving money. Albeit not a lot of money, but they were saving money. In other words, as a service that they were providing, by having a robot, they save money in the long term. And one of the ways they save money was they were, this is before the robot was introduced, so you've got, I need my key. So the robotic is green, open is red. So you can see 60% of patients had open surgery before the robot group was introduced, and only 40% were having conventional keyhole surgery. When they introduced the robot, they were still doing conventional laparoscopic surgery, but the rate of open operations reduced markedly, and therefore they were doing more minimally invasive surgeries, be it conventional laparoscopic surgery, be it robotic surgery. So there were less laparotomies, and that's one of the reasons they saved money. Less conversions, but they knew they could tackle more patients by minimally invasive surgery. So we've looked at lots of studies, different centres. We looked at one individual surgeon, looked at their data, and we've looked at a hospital providing a service, all pointing towards the robot being advantageous. And then what they did in the States, they looked at one state, and they looked at all the hysterectomies they'd done in one state over a period of time. And they had 6,000, so about 7,000 hysterectomies that were done. And they looked at the different routes by which those patients were operated on. And what they found was that the conversion rate, so the rates from going from minimally invasive surgery to having to open the patients up doing a laparotomy rate, was 0.8% in the conventional, in the robotic group, but was about 5% in the robotic group. No, I've got that the wrong way around, haven't I? Sorry. It was 0.8% in the robotic group, but 5.5% in the conventional laparoscopic group. In other words, if you have the robot, you convert less patients. So every 100 patients, another 4 patients were having to have an open surgery because of not having access to the robot. Now, you might say, well, that's not that impressive, really. Well, if I was one of those patients having laparotomy, I wouldn't be happy. But then they looked at the complexity of the surgery that was being undertaken. So you saw initially a simple hysterectomy, as in it was an easy hysterectomy, it was. But sometimes hysterectomies are not easy. You get adhesions if the bowel is stuck, you can get big uteri, which are huge. You can get endometriosis where everything is adherent and there's lots of blood loss. So they looked at the complexity of the surgeries and realized that the robotic surgery patients, actually their operations were much more difficult than the conventional straight stick surgeries, but still the conversion rate was lower. So what was happening was these surgeons that had access to a robot were saying, okay, this is going to be quite an easy operation there if I'm going to do conventional laparoscopic surgery because it's cheaper. And then when they got a difficult patient, they were going to use the robot. So despite the patients being operated on that were more difficult, they still had a lower conversion rate. So that percentage, 0.8% to 5.4, actually probably would have been bigger if they truly randomized the patients to either one modality or the other. And what they also found was that the more experienced surgeons were actually better and had a lower conversion rate, which makes sense. But even when the surgeons were very experienced, when they had a robot, they were still better than if they were less good surgeons. So the robot not only helps the poorer surgeons, it also helps the better surgeons as well. So for the scientists in the audience, you should be saying, show me the randomized trials, not all this sort of retrospective, non-randomized data. Show me a randomized trial. And, okay, we can show you a randomized trial. So I've just shown you all the advantages of having a robot versus having keyhole surgery. Why have I shown a parachute? Okay, so has anybody done the randomized trial of jumping out of an aeroplane with a parachute versus jumping out of an aeroplane without a parachute? No, because that would be a stupid thing to do, okay? To me, having a robot is sensible because it's easier, and to me the evidence is there, and therefore, why do a randomized trial? If there are any medical students and surgeons in the audience, this is an instrument called a ligature. You've probably seen it. We use it all the time, and it costs about €400. This is used for open surgery. €400, we ask for it, we get given it. Has there ever been a randomized trial of this instrument versus just cutting and diatherming? No, because it only costs €400, so nobody's bothered. Because the robot costs that much more money, we have to justify its existence. Is that right? It probably is. But why should we have to justify? At what level does something cost before we have to justify its existence? I don't know. But there have been randomized trials with a robot. Now, I'm going to again talk about the gynecology ones. There have been urology randomized trials that show the patients do better. And there was one randomized trial for robotic surgery for endometrial cancer. So this is one centre where they go up to the patients before the surgery and they randomise them, irrelevant to how difficult they think the surgery is going to be, and they say, right, you're having conventional laparoscopic surgery and you're having robotic surgery. And they managed to do that randomised trial, which is pretty impressive, because somebody had tried to do that before on a different type of procedure, and they said, right, I want to put you into a trial. We're going to randomise you to the robot versus to conventional laparoscopic surgery. And the patients who are American said, I don't want conventional laparoscopic surgery. I want the robot. And they couldn't complete the trial because nobody would be randomised because they said the robot's got to be better, therefore, and that trial never finished. There's one other trial that didn't show a difference they managed to do, but this trial did show a difference. So it's the same surgeons randomising the patients. And what they showed was, again, traditional laparoscopic surgery compared with robotic laparoscopic surgery. So the operating time was slightly less with the robot. The overall operating room time was slightly less. The blood loss was pretty similar, in fact. The conversions, again, so there's 50 cases in each group. So they had a 10% conversion with the traditional laparoscopic group, but 0 conversion with the robot group. 10%. Okay? 1 in 10 patients. The hemoglobin was slightly less decreased with the robot. And hospital stay, again, slightly less with the robot group. This slightly lower hospital stay. That's randomized data. I think that's relatively convincing. So somebody says to me, well, why don't you do a randomized study of your patients? And I said, I could, but if I go up to a patient in the morning and I look at that patient and I think, okay, I'm going to randomise you. Okay, I'll randomise you. Then I look at them and they may be a bit overweight. I may know they have lots of adhesions. It's going to be a difficult procedure. So I think I'm not going to be able to do that with conventional surgery. I'm just going to do it with the robot. So I don't put them in the trial. So I end up just randomising easy hysterectomies with a robot versus conventional laparoscopic surgery. And that probably wouldn't show much of a difference, and I accept that. The robot's not about easy cases, it's about difficult cases. Plus, is it ethical for me to go to a patient that I know is going to have difficult surgery and use an instrument that I know from my own experience is worse or better, and put them in the straight stick group, what I know I'm not going to do as well than I would do if I had the robot? Is that ethical? I don't think that's ethical. Now, I'm not saying that the guys who did this study were unethical. I'm not saying that. But what I'm saying is, for me, I know my own skills are better with a robot for the difficult cases, therefore I can't do that. And it's going to be interesting to see how many more people can do this sort of study. I said there had been other randomized trials that didn't show a difference. And one of the reasons was that they randomise the patients as soon as they got the robot. So they've done one case with a robot and then suddenly randomise them, so that only the second or third case they'd ever done with a robot, they were including a randomised trial. And you can't do that. You've got to use the robot 30 or 40 times, which we really slick with it. And therefore, I don't think those studies are particularly valid. But that's one of the criticisms. Not every single randomised study that's been done has shown a benefit, but the well-done studies do show a benefit. So, what evidence do we have? We have the grouping lots of studies together, their meta-analysis. We have one surgeon's data. We have a service that a hospital offers showing a benefit. We have a state in America looking at all their hysterectomies, admittedly non-randomized, showing the conversion rate is lower despite there being more difficult cases with a robot. And we have a randomized data saying it looks better. So the evidence is reasonably strong. So what does a robot do? So it affords all the advantages over laparoscopic surgery over open surgery. So it's better than open surgery, there's no doubt about that. I think it increases the scope of the operations amenable to laparoscopic surgery and thus increases the number of patients you can operate with that minimal invasive approach. Surgeon comfort, I think, is important, and there's decreased surgical time compared with conventional laparoscopic surgery. So I still do conventional laparoscopic hysterectomies when I know they're going to be easy, and I'm definitely still quicker with a robot. Even if I've got an easy case, straight stick, I'm still quicker with a robot if it's a more difficult case. Decreased conversion to open, that saves money. Reduced blood loss, probably. Short hospital stay, possibly. So what other marker can we use as like a difficult operation? How can we show it's used for difficult surgeries? Well, we have patients that are a little bit big, okay? This is a huge problem all over the world, okay? Obesity, or in this situation, morbid obesity. These patients are really, really difficult to operate on. Now, obesity, obviously an increasing problem, and endometrial cancer that affects the uterus increases with obesity. So we're getting more and more endometrial cancers because patients are getting more and more obese. To operate via laparotomy on a woman of that size, she will have a 40 or 50% chance of getting a wound infection and then will thus be in hospital for about 2 weeks. Plus you're wading through fat. And that sounds horrible, but you are wading through fat to get to the abdominal cavity. It is difficult. It is dangerous. Not only dangerous for the patient, it's also dangerous for the theatre team that are transferring the patient, and it's dangerous for the surgeon because you get a bad back, you're leaning over and you're pulling and you're pushing. It's difficult and it's dangerous. Keyhole surgery makes all those complications much less. And as I'll show, having a robot again makes the operation easier. So one of the reasons it makes it easier is, remember I said we had 3 robot instruments and a camera, and we then had 1 assistant port. Well, what we can do is we can put some more ports in. So robot, camera, and robot. And I've given the assistant 2 ports so they can assist me. As well as having my 3 instruments, they've got 2 instruments as well. So we get lots of different instruments in the abdomen. You might say, well, hang on a second. If you've got 7 or 8 instruments in there, that's an incision of 8 centimetres, equivalent of a laparotomy. It doesn't work like that. You could put 100 laparoscopic ports in an abdomen like that, and they still get very similar pain than if you only had 3 or 4. It's something about a big incision, stretching the muscles, getting your hands in there that causes complications and causes pain. And laparoscopic surgery reduces that, be it robot or be it conventional. But by having the robot operating on those huge patients is easier. It's still not easy, but it's easier. So if we look at complications in obesity, so increasing BMI. So 25, that's what we'd love to be all 25, wouldn't we? Okay, I'm about there, I think. Okay, and as obesity increases, the risk of everything increases. So these are all different parameters: risk conversion to open, risk of bleeding, risk of medical complications. Everything is increasing as the obesity rate, as the obesity of the patient increases. And me operating on patients of BMI of 40 is now really the norm. And sometimes I get a patient with a BMI of 30 and everybody goes, crikey, they're skinny. And I say, no, they've got a BMI of 30, they're overweight. but that just is normal for us, okay? Having big BMIs. We can't do every single patient. I had a lady on Monday that with a BMI of 56, and unfortunately I couldn't complete the operation because she just wasn't suitable. So the risk increases with obesity, but laparoscopic surgery lowers those complications. Randomized paper looking at conventional laparoscopic surgery and endometrial cancer staging. As obesity rate increases, the number of conversions to open increased, such that in this randomized patient, this randomized study looking at endometrial cancer surgery, a quarter of the patients ended up with a laparotomy. They didn't have access to a robot. A quarter who had laparoscopic surgery, conventional laparoscopic surgery, ended up with a laparotomy because they couldn't complete the operation. So let's look at a group, an obese group, robotic, laparoscopic. Operating time in this obese group, there's John Boggess again, the very good American surgeon. The operating time in the obese group was less compared with conventional laparoscopic surgery. The blood loss significantly less. The hospital stay considerably less. So these patients, these morbidly obese patients, BMIs of 45 and 50, are going home the next day after major abdominal surgery, compared with the big laparotomy where they'll be in for a week or maybe 14 days if they get a wound infection. So that's pretty convincing evidence. And again, looking at conversion rates. So robotic, obese, morbidly obese, laparoscopic, obese, morbidly obese. No conversions in the robotic group, but in the laparoscopic group, 9% conversion overall. So converting patients from a straight stick laparoscopic procedure to an open, the worst case scenario, whereas in the robotic group and the obese patients, they had no conversions, showing again that the robot is beneficial compared with conventional laparoscopic surgery. So what will the robot not do? It won't replace a skilled surgeon. You've still got to be able to operate, and you won't remove the need for all laparotomies, where some patients just won't be suitable for laparoscopic surgery, be it robotic, be it conventional. And what you can't do with a robot, you can't leave it idle because it's expensive. So it should be used by all disciplines, so that that service charge cost is diluted through all the patients. And it doesn't like moving particularly far, like moving to the front line in a war zone. It's never been used for that. You can wheel it between theatres, but you can't put it on a truck and wheel it between hospitals. There's a place in Switzerland that do actually do that, but it's not advisable. But remember, it's just a tool. And I've talked about a robot. Is it a robot? No, it's not a robot, which defeats the whole point of the talk, really, doesn't it? So a robot is a slave. It's something that does things automatically once you program it to do something. The robot won't do anything by itself. You have to tell it what to do. You're constantly doing the movements for the robot. It will never do something unless you tell it to do. So really, it's not actually a robot. Sorry about that. So some of the older people in the audience, I include myself, didn't we feel great with our first mobile phone? Yeah? And then suddenly we're on the iPhone 7, 8, 7. And we thought, that's pretty good. Well, where are we going with a mobile phone? I don't know, this is just an example. Little wrist thing, project it on your hand. It's small, okay? It's an evolution. We don't know where we're going. We think the iPhone 7 is the bee's knees. It's nothing. Progress is moving forward. So this is the latest Vinci Robot. So we had the standard which I've used in other hospitals when I've been teaching. It's awful. We had the Vinci S, but now we're on the 4th generation. This is the Vinci Xi. Lots of subtle improvements that make it actually really, really good. Now, if I had a choice between no robot or a Vinci Si, I'd go for the Vinci Si. I'd love a Vinci Xi, but unfortunately, we won't be able to afford that. But you can get second-hand robots, which are about €500,000, compared with the Xi, which is about 2.1 million. And there are companies that deal with the second-hand robots, and hopefully that's what's going to happen to us. So right now, you look at the Xi, you think that is the pinnacle of robotics in medicine. It's not. That's what it is, okay? We're on an evolutionary step. We're right at the beginning. In 30 years' time, I'm going to look at the robot I use and go, God, how embarrassing. Look at it. It's awful. And there are lots of things wrong with it. It's an evolutionary step, and things will continue to improve, will continue to get better as technology advances and as we learn from the things that we've been doing. And where's it going to go? Well, there's lots of places it's going to go. ICAD is a research centre in France, and they're doing lots of things with the robot, the conventional robot and other different sorts of robots. So, for example, you can have a 3D image. I talked about projecting a CT scan. You could literally have a 3D scan version of the patient, and as you click a button, you're clicking between the image and the conventional view in real time. So you could just click a button and suddenly you're seeing a scan of the patient directly from the angle that the camera's pointing. So you're constantly flicking between the two and seeing what you're supposed to be operating on from a scan, what is under this bit of tissue. You could practice your operation, so you could do an operation in advance. Practice what you're going to do on a 3D simulated model of your patient for tomorrow, not just a mock-up patient, of a patient that you've got a scan of. Operate on the patient as if they're there. You could practice. You can have one thing we've got at the moment is something called indigo blue, which is a dye we inject into a cancer, and it goes to lymph nodes. And with the special optics, you press a button and you flick to the blue screen or the green screen, and you can see where the lymph nodes are. Direct the instrument to them, flick back onto your conventional view, and you can see where that lymph node, it stands out. And that's called sentinel node mapping. So you're going for the lymph node by which the cancer will drain to first, which gives you lots of diagnostic information. And that's currently available and it is being used. Now, I've talked about the intuitive robot because that is the most widely used robot in medicine at the moment. It wasn't the first robot. There was another robot many years ago that did a bit of neurosurgery. And there's one around that helps with orthopedic surgeons. But in terms of scope of practice, this is the intuitive one is the most common one. But there are new robots around. This is one by Cambridge Medical Robotics. We were due to go and meet them next week to see their new robot, but unfortunately it's not quite ready yet. And we've been hearing for the past 3 years, another robot here, that they're going to be releasing a robot. Nobody's quite got there yet. And one of the problems is, as soon as a robot company gets near to a product, what happens? Intuitive Surgical buy them out. They buy the technology out, so there's no competition. But eventually that's being stopped, so there is competition coming. But you can see they're all pretty much the same robot arms, but here the console is slightly different. You're not immersed in a patient, you're looking at a 3D screen. Maybe not quite as good, but this is what we need. We need competition to lower the price, because as soon as there's competition, Intuitive Surgical will have to lower their price. So the instrument that will cost €2,000 will probably cost €1,000, making it much more accessible and making the cost effectiveness much more applicable to the real world. This is the sort of latest thing we're hoping is very close to the market. So it's one trocar, so not 4 or 5 little holes. It's one trocar going through the umbilicus. You can see the camera head there. See the 2 camera heads? So you've still got your 3D view. And then look what happens to the instruments. Okay? So that's being made. And the new consoles, you can program. So when this is about to be released, you just literally will plug it into your new XI and you'll be able to do single port, minimal access surgery. That's very close to being on the market. So one small incision. Thank you very much. Yeah, I'm happy to take any questions, unless it's a hard one that I don't know the answer to. Anything at all? Yeah.
You're obviously very enthusiastic about this, and it's a very good sales pitch. But I'm just wondering, are there surgeons out there who are not keen on this? Or would,
yes, when I say not keen, vehemently opposed to it. Because one of the issues is that there are some brilliant laparoscopic surgeons out there who don't want to use a robot, probably because they don't need to, but also there's a bit of the bravadery, I don't need a robot. Now you might argue the way around that I'm big bravado because I've got a robot and therefore I'm better than them. I'm not. there are some surgeons that are brilliant that don't need a robot. But what I would say to them, have a go and see how even better you will be with a robot compared with conventional surgery. But no, absolutely not. There's still a significant proportion of the medical community that think it's not good enough yet. Some of them think that robotics will never take the place of a surgeon, and that's clearly not correct, because the evolutionary steps will mean that we are still involved, but eventually will be replaced bit by bit. So I think there are some people that are burying their head in the sands, but there's some people that don't sort of need a robot or don't feel it's applicable to them. Yeah. Yeah, there's a microphone coming down, so...
Just curious as to where you think penetration could get to if cost wasn't a hurdle in your field.
Yeah, I think it should be reserved for the sort of more difficult cases, and I would never want it to replace conventional keyhole surgery for simple procedures. And it does take a while to set it up and learn how to use it. So I think I think what will happen is which would tend to happen in our building, is you'll have 2 or 3 surgeons using the robot that will get given the difficult cases, and everybody else will do the easier cases with conventional laparoscopic surgery. So it won't be universal, no, and I don't think it should be. And even if it was cost neutral, I still wouldn't want to set the robot up to do a very easy case, because it really would be a waste of time, even if you are slick at setting it up. So no, it won't be complete penetrance. No, it won't. And I wouldn't want it to be.
Sorry, given what happened last week, I wonder, are there security issues around it, particularly where you mentioned the internet? Yeah,
so ours is... you could just unplug it, so you don't need it to be connected to the internet. And I talked about somebody operating from 3,000 miles away. I mean, that has been done, but in the real world, nobody really does that yet, because the setting up is actually the most difficult bit. The sitting down at the console operating is the easy bit, because we're trained surgeons and therefore we can operate. So I think if you were getting to the point where things were being used in remote places, so in the outback or in small hospitals where a surgeon was going to be operating from a major centre, then yeah, that definitely would be an issue, yeah. But we're not yet there with the robot. But in the future, yeah, it could be.
Just a whimsical second question. Does a misspent youth of playing computer games make people quicker to learn or adapt?
There's definitely been some studies where teenage kids pick it up slightly quicker than they've been on the games consoles that haven't. But it is, as the company said, it is very intuitive. It does what you tell it to do, whereas conventional laparoscopic surgery, everything is in reverse. You have to teach your brain how to use conventional laparoscopic surgery. With robotic surgery, it's just learning where the foot pedals are and learning how to do the operation itself, which you should already be skillful at anyway. So yes, there is a bit of evidence of that, yeah.
I'm curious to know what the insurers' view is on it around the medical malpractice. Have there been any interesting test cases?
Yes, there have been. And there was, and about 8 years ago, the share price of insurance surgical dropped because with a few complications. And then this is again where we talk about it is a tool. So if somebody had a blunt scalpel, would they sue the scalpel maker? No, you sue the surgeon. So it's all about the surgeon who's getting the complication. It's not the tool. And I think these court cases got chucked out. But what has happened is that when I first did my first case, I had a proctor fly in. Well, no, that's not true. I start from the beginning. I went to a training centre where we had anaesthetised pigs, and we were docking and operating on anaesthetised pigs to learn how to use the robot. And then when I did my first case, a trainer came and called a proctor that helped me with the first case. I was that bad, they had to leave halfway through the case because I was that slow. But now they're much more into doing 5, 6, 7 cases with a proctor present. So I now proctor and I go elsewhere to teach new surgeons, so they're used to using the robot. So again, it's not the equipment, it's the surgeon that is the problem. But it was an issue a few years ago, yes, it was. It was.
Very good talk. Do you find it a bit isolating? You did mention there's junior doctors there too, but is your head stuck in the console?
It is, and on an easy case, the music will get turned up in theatre and the conversation will be drifted away from me at the console, and I'll be on my own doing an operation. So yes, you can be. And if it's a difficult case, occasionally I'll just say, like, can I just be quiet because I need to concentrate, and that's not an issue. The new consoles that I showed you just at the end, well, there was one console I showed you. So with the intuitive one, you're very much immersed and you're looking down. You can't see anything around you at all. You have a microphone and you have an earpiece, so people can generally hear you, although it's not as good as standing opposite a patient with your assistant there where you can verbalise very easily. So there is a little bit of that, yes, there is. And with the new console, that one that I just showed you, you're not immersed as much. You're sat down looking at a screen on a comfy chair, and therefore you can easily look around and see everybody else, so it's less immersive. And I'm not sure whether that will be better or worse. That's one of the reasons I want to try it. But the Cambridge Medical Robotics, that are one of the new companies out, they've done some research and say a lot of surgeons don't like that immersive feeling. They do feel isolated. Whereas I sort of quite like it because I feel as though I'm in the patient. But it'll be interesting to use the new consoles where you are actually a bit more open and you're not immersed.
If things ever went wrong, like who's there to help you take everything away and do a laparoscopy?
Yeah, so if you hit something big, so I was going to show a screen of a para-aortic lymphadenectomy, I didn't. So you can hit big vessels. So we always will have a junior doctor there that is relatively experienced to undock if you had an emergency. We've had a couple of emergencies. One, there was a respiratory problem with a cardiac respiratory problem with a patient, so we had to undock pretty quickly. And we have an undocking protocol where if the anaesthetist shouts emergency, then I just step out, put some gloves on and help take the instruments out. But the junior doctors there and the nurses are very experienced, so you can undock very, very quickly and convert to a laparotomy if you need to. So that is something that is, yeah, you're conscious of that. Yes. Yeah.
I'd like to know your patient's thoughts on the machine and if the visual of the robot arms is anyway intimidating to them, if they even see it beforehand.
So when I did my, I think, first 10, 15 cases, I consented every single patient to say, look, this is relatively new in terms of my experience of it, and therefore they consented for robotic surgery. And now I consent them for laparoscopic surgery because it's just a tool. Some patients go on the internet and they look at it and they are really inquisitive and want to see it before you do the operation in real life. And some of them say, I really don't want to know. But I've never had anybody that has said, no, you can't do robotic surgery. And it's to the point where I would say, well, I'm not operating on you then, because this is the way I do it. This is the safest way for you. And if you don't want me to do it, then I'm afraid to send you to another surgeon. And what we don't do is, when it's been draped, the arms are very open. And it does look quite daunting. So we have the patient in the anaesthetic room so they don't actually see it. But it's not an issue generally, no.
That was brilliant. And I really appreciated you saying that it took maybe 50 operations to really feel that you were at your peak doing this. And it takes time, and there will be simulators which will make it all seem so much more obvious. But looking back, I think about somewhere between 5-7 years ago, there was a lot of trouble in the States. I think it was the NIH said that far too much was being done robotically in prostate cancer surgery and hyperplasias. And there was a huge row about the money which had been invested in private facilities having to get their profits back. Could you just speak a little bit about that and how that's been resolved, basically? Yeah, so this was Intuitive, are very much an American company, and they act like an American company. Sorry if there's any Americans around, that's not derogatory, it's just a capitalist way of looking at it. And the initial robots were mainly in private hospitals because the hospitals saw that as a selling thing. Come to us, you can have the robot. To the point where patients were coming in saying, well, which robot have you got? Have you got the Da Vinci S or the Da Vinci SI? I only want the SI. So it was definitely driven by that. And I think probably too much, and people weren't experienced enough in using it, and that has changed now.
I think the evidence now for the prostate is that that it is better, not massively better, but it is better in the right hands. And I think the question is with the prostate is that how many prostates should you be removing? And that's obviously a different question in some ways, because it's, well, are you selecting the patients appropriately? Are you operating unnecessarily? And obviously that's not appropriate. But because the complications are much less, then I think the threshold of where you should be operating is lowered. Is that a good thing or a bad thing? I think it depends. But absolutely, there are certainly surgeons that are doing unnecessary prostatectomies, but because it's difficult to know who will have that worse prognostic outcome if the prostate isn't removed. So yes, it was sold at the beginning before the evidence was there. But how do you get the evidence unless people are using it? And that's what's going to happen with the new robots that are coming out. So Cambridge Medical Robots want various centres to start using it and just collect data, randomised data, to sort of show is their robot of benefit. So not just flooding the market, is just getting the data there first before they actually create a product that goes on the market. Yeah.
I think we're going to call there. Okay, great. I'd love to thank Matt for joining us from Cork this evening, and for the audience and all the really interesting questions. I think it's been a really interesting talk about the future of robot-assisted technology. The exhibition is actually now closed, but it's open until Sunday, so definitely do drop back. And Matt's website is really informative for anyone who has any more kind of questions or is interested in the topic. It's robotsurgery.ie. Yeah, brilliant. Thank you very much.
Thank you. I figured out if you lift it up.